preterm babies that when they're sound asleep, their cells drop into the low 90s. But if they're they're violating their saturation range, then they're violating their saturation range. And you should not do that when you're sleeping. Now, there is variability there, and you've got some kids that, are there kids at home doing that are dropping their sat, term newborns that never went through the NICU that drop their sats to 89 and sometimes during REM sleep? Yeah, I'm sure there are. But those aren't ones we know about. If they come to our attention, they drop their sats into the 80s when they're in sleep. That's not normal, and that may not mean they have respiratory distress, but they have some disorganized breathing and probably some apnea, short apnea while they're sleeping. So that's a problem that you know about.
Are you looking for a number, because if it's a term baby that is there and just having some problems, generally you want to go by, what, your 92. If it's dropping below 92 and staying down, then...
We set our low sat alarm for a term baby at 92. If they're worrying us about pulmonary hypertension, we set the low sat alarm at 95. Preterm infants, we set our low sat alarm at 88. So if we have a term baby that we're not necessarily worried yet about pulmonary hypertension and they're on supplemental oxygen, we set the low alarm at 92 and the high alarm at 99. And the high alarm at 99 is just so we know to wean. If they're on supplemental oxygen, we don't necessarily want to make them have 100%. But as far as putting a protocol in place that tells you what to do with respiratory rate and saturation and heart rate and things like that, I've never seen anything like that.
Okay.
Well, you should have a sat range that you work with, and it should be a sat range that all your docs agree with, and that they use the same, roughly. And, a lot of the other stuff is really hard to put on paper. Just again, a lot of this is common sense. Are they improving? Is their saturation normal? Is their respiratory distress getting better? I have nurses come to me all the time and say baby sats 100 and he's grunting and look at me like, what are we going to do? I say, he's going to grunt. If we had a chest x-ray that shows he's going to have pneumothorax or something like that, they just watch him and keep the sat monitor on and make sure they don't get worse. It's hard to quantify on paper, though you all know what a baby looks like when they're getting better. And again, that's really the key. If you're keeping, that for a short period of time, a few hours, it's okay to watch a baby that's not getting better. If they're clearly getting worse, you probably may not want to watch them for a couple hours. But if they're really not sure which way they're headed, but they're okay, meaning they're satting okay, and and they're breathing reasonably well and comfortably, then it's fine to watch them. If after a couple hours that hasn't changed at all, or they're worse, they need to go see somebody else.
I think one of the things Joanne kind of alluded to is if you have somebody that's, the baby, respiratory rates in the high 80s, 90s, and heart rate is up, realizing that is not a norm, and because it wasn't up in our NICU, but we have had a pediatric patient here before, and with a heart rate in the high, 220, 240, that sat all night, and when I got here in the morning, it wasn't too long, we had Mandy coming down, but mean, realizing that those are conditions where
But you
you
do
gotta
have,
throw up a red flag, and amiodarone was given this as soon as the baby
but
died.
do you not have alarms on, I mean, you have alarm protocols on your monitors for age, for newborns and children. I mean, what, you gotta set the alarms. You know, if they're violating those alarms that you set, then that's a problem. For instance, if you have a baby that's sitting there and breathing 80 times a minute, which is always gonna be better, you're counting than the monitor. But they're breathing 80 to 90 times a minute, then what else do you need to know about that baby to know if that's a real big problem? Okay, but looking at them on a physical exam, color, tone. You got them on a sat monitor and it's saying 100. Say it's, the baby's in 30% oxygen. And you're looking at this baby that's breathing 80 times a minute. What else are you gonna look, what else do you wanna know about the baby?
Work of breathing. Look for work of breathing.
Sure, is this baby retracting sternum to backbone? Or is the baby just, you know, breathing 80 times a minute and looks pretty comfortable? And, you know, I would say a baby that's an hour old breathing 80 times a minute and not in distress, other than a little bit of tachypnea, is okay to watch, provided they're satting well and so forth. A baby that's breathing 80 times a minute and is retracting hard, that is probably needs a chest x-ray right then. And even though some of those kids will look better in an hour, but it's how the baby looks is a big part of it.
The other thing too is just looking at the stable acronym. I mean, if you have a baby that's had some transition issues, I mean, making sure you're thinking about, Dr. Dominic said this, but well, wouldn't we also get labs? Well, absolutely, because you're using the stable acronym as a post-resuscitation or post-stabilization approach to the assessment and the care of this newborn. So that was sort of, we didn't say it out loud, but you use the stable acronym.
And the other thing is when you draw your labs, if the baby's gotten to the point they're worrying he's been breathing hard enough or needing enough help that you're worried about the baby and you're gonna order a chest x-ray and labs, it's going to take you an hour to get your chest x-ray, your cap gas, your blood culture done, get a CBC back to look at. And then there's another set period of time. If he still looks the same and you got all that stuff back, you really ought to be thinking of, even if it all looks pretty good, this kid hasn't changed, you've got all this stuff back. The other thing is, if you have a baby that's breathing 80 to 90 times a minute, but they are not retracting all that much, they're 5 hours old, can you feed that baby? So then, part of your discussion also has to be, how long can you maintain a baby on IV fluid in your institution? So it's not only, you know, CPAP vapotherm, but if you can't feed them or you have to gouage feed them, how long are you gonna do that in your institution? Or using, are you gonna keep somebody on an IV? Do you have those capabilities for an IV for 24 hours or 36 hours? You know, it's another one of those things for, if you're keeping kids that have a little bit of respiratory distress for an extended period of time, then you have to have IV capability. For an extended period of time. Yes, sir.
I've had a couple chest x-rays, the impression comes back consistent with TTM.
Yes.
What does that mean?
All right. All right. TTN is something, again, that overlaps with slow transition out of the labor and delivery to extraterrestrial life here. It's usually a term or near term, but kids are tachypnic, sometimes really tachypnic. They can grunt, they can retract, have nasal flaring, blue and need supplemental oxygen. You know, the thing is that the presentation clinically of a baby with transient tachypnea certainly can overlap with pneumonia, or if it's a late preterm baby, RDS, a pneumothorax. So I'm going to have to get a chest X-ray to sort some of this out. The oxygen requirement is often highest soon after they develop this, and most kids that have transient tachypnea develop this in the delivery room or immediately thereafter. This isn't something that shows up at a couple hours of age. So this should start pretty soon after they're born, if not immediately. And this is what, you know, it often sort of looks like. This is a baby that has haziness everywhere, although I'm not sure this is the best, but you sort of get the impression that the haziness is maybe worse in the perihilar area. It's a little denser in there. The lung volumes are always normal to high. So these kids are often what normally expanded, if not hyper-expanded. So they really don't have airspace disease. This is they have too much pulmonary fluid on board, and their lymphatics and their blood vessels and veins look engorged. And they can even have, I don't think this baby has it, but you can also see pleural effusion, small ones in the bases. So, clinically, what these kids usually do is they are tachypnic, need a little bit of oxygen from the start, grunting and groaning some, and then anywhere from minutes to a few hours, a lot of them will get better. And if you get an X-ray at an hour of age, well, if you look at one the next day, on a lot of those kids, these sorts of changes are already gone. It just means they've mobilized this fluid clearly. Some kids, and that's always is a reassuring thing that tells you this was transient tachypnea, because there isn't anything else that gets better that fast. So pneumonias don't clear that fast. RDS doesn't clear that fast. Meconium doesn't clear that fast. So there's things where these kids are working a little hard to breathe, and their term and near term, and their history, the mom's history hasn't been worrisome, and you get an X-ray that sort of looks like this, and if that's clear the next day, then it probably was transient tachypnea or something pretty close to that.
I guess my question was, can a radiologist really be that confident and say that it's TTN?
They can say it's consistent with TTN. They can't say it is. And the only way you can say it is get that follow-up X-ray, and that's what it was, because it's better. But can a baby that looks like TTN have a pneumonia in there? Sure, they sure can. RDS usually doesn't look like that, because RDS in preterm babies is a disease of low lung volumes. Unless you put surfactant in there, and then all bets are off. It looks like anything. But yes, if they see this sort of X-ray, they say this is most likely TTN.